Good morning, everybody. So we will start today mineral metabolism of iron. We will discuss with the following points: introduction, RDA, sources, absorption, transport, and storage of iron, and disorders of iron metabolism. Iron is a very important element for the living organism, for human being. Though it is very important, its requirement is very less. That's why it is under the category of trace element. Last class we have known what is trace element. The element which is required less than 100 milligram per day comes under the category of trace element. Total body content of iron is about 3 to 5 gram, distributed mainly in hemoglobin about 75%. Others are myoglobin, cytochrome, iron sulfur protein, cytochrome P450, catalases, peroxidases, xanthine oxidase, tryptophan pyrrolase, and non-heme iron. These are the ferritin, transferrin, hemosiderosis. Actually, this non-heme component is the storage or transport form of iron. Function of iron, as it is important component of the hemoglobin, it is responsible for transport of oxygen from lung to peripheral tissue and carbon dioxide from the peripheral tissue to lung. It is very important for electron transport chain, especially iron sulfur protein, cytochrome. It is involved in detoxification reactions, especially the enzyme cytochrome P450. Catalases and peroxidases act as antioxidants. It is again very important for purine degradation, as it is an important component of xanthine oxidase. Metabolically, it is very important for tryptophan metabolism. Recommended daily allowance for adult male, it is 10 milligram per day. For menstruating female, 20 milligram per day. And pregnancy and lactation, 40 milligram per day. For children, it is 10 to 20 because they need more iron for growing age. Main sources are green leafy vegetables. About 20 milligram iron is available in 100 gram of vegetables. Pulses, 10 milligram per 100 gram of pulses. In cereals, it is about 5 milligram per 100 gram. Jaggery is a good source of iron because this is made in the iron vessel. So iron component of jaggery is very high. Liver, it contains 5 milligram of iron per 100 gram of liver tissue. Meat, 2 milligram per 100 gram. Good source of iron is also in dry fruits. But milk is a poor source of iron. About 0.1 milligram per 100 ml milk, it is present. Now, factors that increase iron absorption. These are the vitamin C. Why these are important? Because we like when we give iron to someone for therapeutic use, we would like to give those factors along with the iron which increases absorption. Again, we would like to restrict those items which hamper iron absorption. Okay, so that's why factors increasing the iron absorption and decreasing the iron absorption are important. Vitamin C, gastric hydrochloric acid, small peptides, cysteines, they facilitate iron absorption. Phytates, oxalate, phosphate, they decrease iron absorption. So when we give iron to a patient having anemia, we give vitamin C along with the iron so that better absorption of iron occurs. Now here, absorption, storage and transport and utilization of iron. This is a intestinal lumen, enterocyte, blood and hepatocyte, liver tissue. Now, the iron we take in the food is present as ferric form. However, to cross the cell membrane, either to enter or to get exit, it has to be in ferrous form. So, iron we are taking in ferric form, it is bound with the say some protein or some organic substances in the food material. With the help of hydrochloric acid of the stomach and organic acids, this ferric ion is released in the duodenum. Okay. Now, this ferric ion to get absorbed, it has to get converted into ferrous ion. It needs reduction of the ferric ion. It is the ascorbic acid, cysteine that cause reduction of ferric ion to ferrous ion, and another protein is there in the duodenal wall, cytochrome. Here, one protein will be there, cytochrome B, that is having the ferroreductase activity also. So, it is reduced to ferrous ion. Now, it will be carried to the inside of the cytosol of the enterocyte, that is carried by a special protein called divalent metal transporter, divalent metal transporter 1. It is present in the brush border of the enterocyte. Okay. Now, by divalent metal transporter 1, it is carried to the inside of the cell as ferrous form. Remember, ferrous form is very highly reactive. Okay. It reacts with ferrous form, it reacts with hydrogen peroxide generated inside the cell, and it produces hydroxyl ion and hydroxyl radical, hydroxyl ion and hydroxyl radical. This hydroxyl radical is very potent oxidizing agent. It oxidizes the DNA component of the cell. So, in no way this ferrous ion is wanted inside the cell. That's why another enzyme, it immediately acts, ferroxidase. It immediately acts on the ferrous ion and oxidizes into ferric ion. Okay. Now this ferric ion, it combines with apoferritin and produce ferritin. Ferritin is the storage form of iron in the enterocyte. Okay, and also it is storage form in the liver also, that we are coming. So this is ferritin is storage form. It is stored as ferric ion in the ferritin. Some amount of ferrous ion it gets directly through the branch border, basolateral membrane. It passes to the plasma. Okay, plasma through ferroprotein, one carrier protein called ferroprotein. So this one combines with apoferritin, and forms ferritin. And some amount of it passes directly by divalent metal transporter. It is called ferroprotein, ferroprotein, not protein, ferroprotein. Okay, just remember, through this portal the iron has to pass, so it is ferroprotein. Now at the time of necessity, this ferritin will release iron for utilization. So it has ferric form, it will be reduced to ferrous form by the ferroreductase in the duodenal cell and transported through this ferroprotein carrier to the plasma. Once again, this is very dangerous to remain as ferrous form. So this will be oxidized by the ceruloplasmin or peroxidase 2. Okay, and it will combine with the apotransferrin to form transferrin, and transferrin is the transport form of protein. This is the storage form, this is the transport form. Then it will be carried to the respective site of its utilization in bone marrow for hemoglobin synthesis, then muscle for myoglobin, and other tissue for synthesis of the enzyme containing heme. Some of the transferrin will be taken up by the liver, kidney, spleen for storage as ferritin and hemosiderin. This is understood now? This much. Whenever the iron has to go out of the cell from the enterocyte, it has to be in ferrous form. This you have to remember. Now here is again the last slides, a bit modified one. Some of the iron containing molecule like heme, it can get absorbed in the enterocyte directly through heme transporter. After getting in, it is iron is released and it is converted into ferric form and it is deposited as ferritin. This is the thing in this slide, something extra. Now this hepcidin, this is again a carrier protein for iron. This one, it carries iron from the enterocyte directly to the portal blood. Okay. So the iron is transported as transferrin. 65% is used for hemoglobin synthesis, and myoglobin, iron containing enzymes, they require about 30%, 15 to 30%. And as we know, RBC has a lifespan of 120 days. After that, it will be destroyed. So RBC will contain heme. What it will do? After 21 days, all RBCs are destroyed and hemoglobin degraded, and iron is released and stored as ferritin and hemosiderosis. It occurs in the macrophages of spleen, bone marrow, liver. Now, one thing you have to note. See, after utilization of the iron, there is no way out. It has not been excreted. It is stored as ferritin. Again, it will be utilized. So, there is no excretion of iron. It is repeatedly and used again and again. Okay. So, how iron is regulated? Now, iron absorption is regulated right at the site of absorption in the enterocyte. Okay. This is called mucosal block theory. Note it, you may get short note. Mucosal block theory in regulation of iron absorption. When it is required, mucosa will be allowed to absorb the iron and release to the systemic circulation. When it is not required, this mucosa will be blocked to absorb and iron absorption will be stopped. So, when demand increases, absorption increases. When demand decreases, absorption also decreases at mucosal level. Sorry, spelling mistake. Protein, hepcidin. Hepcidin, it is a protein synthesized from the liver. Okay. Now, hepcidin has a down regulatory effect on divalent metal transporter, both 1 and 2, means at the entry also and at the exit also in the enterocyte. Hepcidin is most important for regulation at the mucosal level. When iron is not required anymore, hepcidin is secreted, so the gate in the enterocyte is closed. Divalent metal transporter is closed. This is the mucosal block theory. Now, iron is called one-way substance. As I told you, it has a route to enter only, but there is no route to exit. I mean, there is no system of fission of the iron after utilization. After it is utilized, it is again stored as ferritin, and again it will be used when the demand is there. However, some degree of iron is very negligible amount are excreted in the sweat, hair loss and bile. It is not a mechanism of excretion of the iron. It is because it normal phenomenon, the sweat will come, iron comes out. Okay, hair falls out, iron falls out. Iron also is removed. So this is about 1 milligram per day. That is why a supplementation of iron is required. because one question you may be thinking that once the iron is there inside the body, what is the need of further taking iron if there is no exit? Because in a natural way, with this thing some amount of iron is removed from the body that we have to replace. Diseases of iron metabolism. Iron deficiency anemia, it is due to the deficiency of iron. For increased iron absorption, there are two diseases, hemosiderosis and hemochromatosis. Another iron any type of anemia is there, anemia of chronic diseases. So we will discuss. Iron deficiency anemia. Causes of iron deficiency anemia are increased demand, decreased intake, chronic blood loss. If somebody is having say piles, there is continuous bleeding in the stool, so there will be chronic loss of blood and there will be depletion of total body iron content. Okay, so he will have anemia. Lead, this is a heavy metal that hampers activity of ELA, which is responsible for hemoglobin synthesis. Repeated pregnancy is most important cause. In Indian context, maximum of the women they are in rural areas, they are subjected to repeated deliveries, and whatever iron is required to replenish the iron requirement, they do not get. So there will be, this is the most important cause of anemia, iron deficiency anemia. Then one disease called achlorhydria, Ulmer-Wilson syndrome. There also iron is absorption of iron is hampered. Symptoms, as there is hemoglobin is very less, there will be apathy, then poor school performance, sluggish and dull child. The anemia will be microcytic hypochromic. As hemoglobin is less, the RBC will have, when stained, it will be deeply stained at the periphery, that area becomes less. So this is sign of hypochromic anemia. There will be colonychia, brittle nose, brittle nails, then glossitis, angular stomatitis, because iron deficiency in the village area is associated with usually vitamin deficiency also. So there will be glossitis and angular stomatitis. In laboratory investigation, serum iron level decreases. Normal is usually 100 to 150 microgram per deciliter. Iron binding, total iron binding capacity increases. Normal is 250 to 400. See, when iron level is low, the binding iron that is bound to the transferrin will be less. So capacity of iron binding capacity of transferrin will remain high. So there is total iron binding capacity, it goes more than 400. Hemoglobin decreased, normal is 14 to 16 for male, female 13 to 15. These are the biochemical parameters. Other incomplete hemogram, if we go, there will be so many findings. Okay, packed cell volume will be less, and all these things. That is the cellular part. So we remain in the biochemical part. Now, disorders due to excess of iron. One is hemosiderosis. This is due to the increased absorption of iron, commonly found in the Bantu siderosis. Bantu tribes of the South Africa, they used to have this type of iron overload, disease of iron overload. It is their system is associated with increased absorption as well as increased storage. Hemosiderosis, it is disorder of iron, excess iron deposition, deposited in skin, liver, bone marrow, spleen. In the skin, when these iron is deposited, the color of skin becomes yellow to brown. There is a discoloration of yellow to brown discoloration of skin, that is called bronze skin. Bronze skin. Combination of bronze skin, diabetes and cirrhosis are known as bronze diabetes. In thalassemia, there is ineffective erythropoiesis and repeated blood transfusion that increases the body iron load. That also cause hemochromatosis. Iron chelating agent like desferroxamine, deferrous rocks are used for chelating the iron and reducing the iron load of the body. Now, what happens to the iron metabolism in anemia of inflammation or chronic diseases? When there is inflammation of the body, that is caused by many types of inflammatory mediators. One of the inflammatory mediator is IL-6, interleukin 6. This interleukin 6, it stimulates secretion of hepcidin. It stimulates secretion of hepcidin in the liver. Hepcidin. And this hepcidin, as I told, it has a down-regulatory effect on divalent metal ion. Okay? Note, it is having both inhibitory action on divalent metal ion, but some degree of iron is absorbed. Okay? But it is not released in the circulation. So what happened? There is storage of ferritin in the enterocyte. Okay? Now, some amount of ferritin is secreted in the plasma. That is proportional to the amount of ferritin stored in the body. So, when we measure body ferritin level, plasma ferritin level, that reflects the amount of iron stored in the body. Okay? So, what happens here? We have normal ferritin because enterocyte, they are absorbing the iron, but they are not releasing the iron to the plasma. Moreover, the hepatocyte, spleen and bone marrow, they have a tendency to store the iron, to conserve the iron content of the body. So, they are also storing as ferritin. Now, as there is anemia, hemoglobin will be less, total serum iron will be less in both the case, iron deficiency also, anemia also. Percentage saturation of the iron will be less in iron deficiency anemia and also in the chronic disease, because free iron is not there for binding to the transferrin. Total iron binding capacity it increases, but in chronic disease it decreases, because transferrin also, apotransferrin also, it is synthesized less due to the inflammatory vessels. Okay, that's why the binding of the available apotransferrin is almost fulfilled, so that the binding capacity goes down. Ferritin, in the iron deficiency, it is decreased because of storage is not adequate, but in case of anemia in chronic disease, it is normal or high, because all the hemopoietic system, including enterocyte, they are conserving the iron. Total iron binding capacity you understood, no? In chronic disease, the available iron, it binds the apotransferrin, which is also very less in amount. Okay, so even though iron is less, it occupies all the sites of all the binding site of apotransferrin. Okay, that's why the binding capacity is low. So next we will start copper metabolism and case study on Wilson's disease. So we will discuss enumeration of dietary sources of copper. You should be able to enumerate dietary source of copper. You should be able to describe normal metabolism and function of copper, describe disorders associated with copper metabolism like Menkes disease, Wilson's disease. These are the important disorders, and some other disorders are there. So copper is also a trace element. Total body content of the copper is 100 milligram. The daily dose, recommended dose of copper is adult 1.5 to 3 milligram, children 0.5 to 2 milligram per day. Tolerable upper limit is 10 milligram. Should not take more than 10 milligram, otherwise it will cause GI problem. Sources are seafoods, organ meat, liver and liver, spleen, kidney. These are good source of copper. Legumes and cereals are good source. Fruits like papaya, apple, coconut, these are good source. Chocolate, nuts, dry fruits, they are the good source of copper. Absorption of copper occurs in stomach and small intestine. Absorption ranges from the 20% to 50% the total ingested copper. Animal protein, citrate, phosphate facilitate copper absorption. Zinc, cadmium, phytate, ascorbic acid, they hampers copper absorption. Excretion of copper is mainly through bile. 85 to 99% of the copper is excreted in the bile, and small portion is excreted in the urine, 1 to 15%. Copper metabolism in normal person. So copper, after ingested, this is absorbed in the duodenum, small intestine. The enterocyte, they have a copper carrying protein, copper binding ATPase. Copper binding ATPase, this protein is encoded by the gene ATP7A. Once it is absorbed, it is released in the circulation and it gets bound with the albumin. Then it is taken up by the hepatocyte. There dissociation of copper occurs and it is released from the hepatocyte through another copper binding ATPase, which is encoded by the gene ATP7B. It is ATP7A, this is ATP7B. Once it is released from a hepatocyte, it is excreted some portion in the bile, and another part it binds with the ceruloplasmin and taken to the area of requirement. Biochemical function, it is an important component of ELA synthase, so it is responsible for hemoglobin synthesis. Ceruloplasmin, important for iron carriages because it is ferroxidase. So ferrous ion to convert in ferric ion, this ceruloplasmin it acts in the plasma. Then hepcidin, it is a multi-copper containing divalent ion transporter. It carries iron also. Cytochrome C oxidase, it is a terminal enzyme for electron transport chain. So it is very important, copper is very important for normal electron transport chain functioning. Catalase, it is again a antioxidant enzyme responsible for antioxidant activity. Lysyl oxidase, this is responsible for normal elastic tissue formation. So copper is required for normal bone, heart functioning. Dopamine dehydroxylase, copper is a cofactor. This converts dopamine into norepinephrine. So normal functioning of the brain also is, for normal functioning of brain also it is, copper is required. Tyrosinase for melanin synthesis. So normal skin color development requires copper. Amine oxidase for metabolism of tyramine and other amines, the copper is required. There are some non-enzymatic proteins. In liver it is hepatocuprine. It is thought to be storage form of cuprothiomin. Brain, cerebrocuprine, RBC, hemochromatosis, bone marrow, erythrocuprine. Their specific function is not yet known. Now, due to the deficiency of copper, an important disease which occurs is Wilson's disease. A 19-year-old girl is admitted in hospital with complaint of pain in the abdomen, moderate anemia. On examination, there was pallor, moderate hepatomegaly, Kaiser-Fleischer ring around the cornea, and few neurological symptoms are noted. It is suspected as Wilson's disease. Here, the name of the disease has been given, but sometimes you may not be given the name. You will be asked to what is the possible disease. There you have to see the findings in the question and write the name of disease. In that case, you will be given laboratory investigation also, so that you can identify the disease. So, mention the cause of Wilson's disease, enumerate other clinical features associated with disease, explain the biochemical basis of hepatomegaly and Kaiser-Fleischer ring, enumerate biochemical investigations required to diagnose the condition, How can this patient be managed? Let's see. Wilson's disease, it was first described by Samuel Alexander Wilson in 1912. This is disorder of copper metabolism. There is hepatolenticular degeneration. Hepato means liver damage will be there. Lenticular means lenticular nucleus of the brain. These will be damaged. This is the most important component of Wilson's disease. That's why this disease also called hepatolenticular degeneration. This is the autosomal recessive disease. The ATP7B gene mutation in chromosome 3 is responsible for the Wilson's disease. This is the gene encodes copper binding ATPase, which is responsible for release of copper from the hepatocyte to systemic circulation. Incidence is 1:100. Disease incidence is 1:4 to 1 lakh, and carrier is 1:100. See, this is the gene mutation of the gene responsible for Wilson's disease. So the incorporation to the ceruloplasmin, excretion through bile, it will not be, it is not occurs, and there will be storage, there will be abnormally stored copper in the hepatocytes, brain tissues, and also in the hematopoietic systems. Now, these are the things it involves. When liver is involved, when it usually involves liver, so there will be hepatomegaly, enlarged liver, jaundice, acute hepatitis, hepatic failure, cirrhosis. Hepatic failure and cirrhosis, these are the terminal, they are the terminal conditions of the hepatic involvement. See, hepatomegaly means there is enlarged liver. Cirrhosis, in cirrhosis what happens? Their liver becomes very small, sclerotic liver. Okay, that's why in the beginning, at the time of first inflammation, the liver size will be enlarged, but ultimately it will get cirrhosis, and there will be fibrosis of the liver, and it will become small. Brain, there is lenticular nucleus of the brain is damaged, so there is deterioration will be, there will be deterioration in school performance, there will be behavioral change, in coordination, resting and detention tremor will be there, dystonia, dysarthria, dysphagia. Dystonia means the tone of the limbs. See, we have a tone, no? It doesn't fall like that, slowly falls. So this is the tone. So there will be impaired tone. Dysarthria means difficulty in speaking. Dysarthria means difficulty in speaking. Then dysphagia means there will be difficulty in swallowing. Okay. There will be excessive salivation, marks like faces. All are due to the lenticular nucleus involvement. In arthritis, in bone, there will be arthritis, there will be ricket. In hemolysis will be there in case of in RBC. Then Kaiser-Fleischer ring. You can see a brown discoloration around the cornea. Copper is deposited in the decimate membrane of the cornea, decimate layer of the cornea. Cardiomyopathy, as elastin formation is defective, so there will be cardiomyopathy. Elasticity of the heart, aorta and peripheral big vessels will be less. That's why there will be aortic aneurysm, the dilatation of the aorta, okay, and at times there may be rupture of the aorta. Proximal tubular dysfunction will be there in Wilson's disease. Diagnosis by serum copper estimation, it will be low. Urine copper estimation it will be high, more than 100 milligram microgram per 24 hour. Ceruloplasmin it will be low, less than 0.2 gram per liter. Normal value is 20 to 50. Liver biopsy, when liver tissue is taken and biopsy is performed, there will be content of copper in that tissue will be very high. It will be around 250 microgram per gram. Genetic testing to identify the mutation. For treatment, a chelating agent called penicillamine is given that chelates the copper and remove from the body. Penicillamine, trientine, these are the chelating agents. Zinc salts are given. It interferes absorption of copper from the gut by thereby reducing the load of the copper, and it induces erythrocyte metallothionein. Okay, this is also responsible for removal of the copper. Liver transplantation, when these things are failed, then liver transplantation may be thought of. There's diet. In diet, there should be restriction of food containing high copper like liver, brain, chocolates, mushroom, shellfish, nuts. Menkes disease, last time also we have read. This is Menkes steel hair syndrome, X-linked rare disease disorder. Incidence is 1:2 lakhs. Causes mutation of the gene copper ATPase ATP7A. This is the here ATP7A. There will be absorption of copper in the duodenum enterocyte, but it will not come out in the circulation for biological function because of this copper carrying protein is not normal. Copper deficiency despite adequate ingestion of copper. Normal copper ingestion will be there. This will not be absorbed. So, if we take normal copper also, bioavailability of copper will not be there. Characterized by coarse, detailed, depigmented hair, there will be mental retardation, abnormal connective tissue growth, skeletal defect, and neurological abnormalities due to deficiency of copper. Diagnosis: low copper in plasma, urine, liver, brain. On electron microscopy, there will be pili-torti, that means short and detailed hair that appears flattened and twisted here, this one. Mutation analysis may be done to identify the disease. Treatment is, as it is not absorbing in the system, we have to give injection, but that has to be started early in the life. Within few days of birth, it has to be started. Daily copper injection may improve the outcome if it begins within days after birth. Other treatments are symptomatic. Whatever symptomatic problem is there, accordingly it will be. Other disorders are ceruloplasmin anemia is there. So ceruloplasmin level is, if it is low, less, then there will be less copper bioavailability, copper deficiency anemia, cardiovascular diseases, and hypopigmentation. These are all due to the enzymes responsible, all the enzymes which are utilizing copper as cofactor or their component. Okay. Thank you.